woman in some state or Washington State. What do they do all day? Play cards, right? Well, in some places that might be true. I'll be honest with you, there is downtime. Some people say, I'd rather work the night shift because, I'm a night person. But in all honesty, there is no time to play cards. Everybody should always be doing something. And the moment when there's too much downtime, a proper ran hospital should say, okay, each nurse started with 4 patients, half of them are down to 2. So let's go ahead and let somebody go home. And by the way of staffing, they have a list, or they have a list on it. And so they put them all together, crunch them all together. You can go home. It's your turn if you want to go home. So we're not playing cards, guys. We're moving things along. Okay? So I said that to say, well, what does the nurse do all day? And in order for you to function as the nurse, you got to think like the nurse. Okay? So right here, we're giving you a lot of information. Your Professor Jenny, your Professor Silva, here in this classroom here, a lot of information. As you can see, this is hands-on. Over there, it's a little bit more theory. You've got to pass your test. You can't be here unless you pass. But let's talk about real life, real hands-on, what does the nurse do? So let's talk about the nursing process first of all. Okay? So I want you to go ahead and write these titles here. Okay? And first of all, what the nurse does is assess. And go ahead and leave 3-4 lines in between. And after we assess the patient, we're going to plan. Okay? And after we've planned, we're going to do interventions. And then after that, we're going to evaluate whether what we did or not worked. Okay? So let's talk about the assessment. Okay? Remember, week 1, head to toe assessment. You went home, studied it. We came back. Did you guys do? We did do our assessment head to toe, right?
Yes.
We got through that. Okay. So actually, you did that last week. And that's why it's not connecting. So here's the idea. When you go into your floor, you walk in at 7 o'clock. I'm just going to say in the context of 7 a.m. to 7 p.m. And your nurse is going to, the night nurse is like, come on, day shift, let's go, we got to go. They've been there all night. So let's get our report. You get a report on A bed, B bed, okay? 3A, 4C, and 5A. Those are your patients. You got 5 patients. You're going to go through the next half hour, you're going to go get a report. The nurse is going to give you a report. It's going to be admission, diagnosis, it's going to be all sorts of information. Okay? And then after that, it's my job to go back and assess all my patients. So the assessment has to do with you getting to know the situation and the problem of the patient, get to know the demographics, 69-year-old male, English speaking only, or Spanish speaking only, or different language, culture, past medical history of, let's say, diabetes. You can write out whatever you want. I'm not giving you any information yet. Diabetes, hypertension, just demographics. And then why they were admitted to the hospital. That's your assessment. Okay? Easy enough? I mean, that's just basic information. But then you have to figure out, or be told, or research, why did they come to the hospital? What kind of symptoms did they have? Let's say abdominal pain, right? Let's go with this NG tube insertion for today. Abdominal pain, abdominal distension, nausea, vomiting. Okay? They come to the hospital, they get some exams done. KUB indicates small bowel obstruction. CT scan of the abdomen, small bowel obstruction. Okay, we're on the same page. We have a diagnosis. Okay? Based on that diagnosis, was created by who? A doctor. Who what? Created this diagnosis out of thin air? No. Based on what? Assessment. Your scientific data. We have an x-ray. Same with the school. Why do we need a diagnosis to begin with? A medical diagnosis. So that they know exactly how to treat. Because based on evidence-based practice, the doctor knows small bowel obstruction is NPO, and you have to write this down, NPO, daily x-rays, IV fluids, pain control, nausea control, right? Ambulation to help this process, NG two-wall suction, okay? The continuous wall suction. And that process in the first 24 hours, 36 hours, is going to hopefully allow the patient to get better. Okay. So when we're talking about, this is also kind of maybe known as ADPI, okay? I learned it a little bit more like this. It is pretty much the same thing. But we need this foundation to be able to do our care plan. So that's why I'm going this route. Okay. So we have the assessment, we have the symptoms, we have the medical diagnosis. We've assessed the abdomen, and what kind of abdomen are we going to, is the patient going to present with? Distended. Bowel sounds are going to be diminished, right? Because nothing is flowing. The peristalsis is, everything is not doing so well. Okay, so we've got abdominal distension, and remember the percussion? Ding, 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 ding. You're going to hear that little drum sound. Air, distension, decreased bowel sounds, no bowel movement, and everything's coming up. Why? Because the patient continues to develop gastric products that are going to need digestive juices, if I can just say it like that. That's why you throw in that NG tube to decompress the stomach, remove the air, remove the fluid, remove the secretions, remove the acidity that makes them sick. Okay, so that's our assessment. Okay, so we have a small bowel obstruction. Let's move on. When we have our small bowel obstruction diagnosis, we've assessed the patient and we discovered everything that I just said, all their symptoms. Now we can start planning. Okay, I'm going to go very quickly on this. What would our plan be for this patient? NG tube insertion, NG tube suctioning. Okay, and our plan is going to be NPO. You know, the plan is based on the doctor's orders. IV fluids, nausea control, Zofran, Reglan, okay, and then ambulate the patient. Why? We don't want the patient stuck in bed. What happens when there's no ambulation? Anybody ever have a little pain control vacation? You know? Pain, you feel sick, right? You get a flu. You don't feel good. You have a headache. What do? Take your medicine and go to sleep. Right? But what happens when you're doing that in the course of a hospital for 24, 48, 72 hours and you don't move? Muscle atrophy. You feel sick. And guess what happens to the motility of your digestive system? There's no movement. Okay? So if we can get the patient ambulating, chances are that we're going to do, so the plan would be that the patient is going to ambulate, the patient will be NPO, okay? The patient will be given medications. When we plan, then we have our interventions, okay? Now we can have our interventions, and that is from your textbook, it's from your physiology, I'm sorry, not your pathophysiology, your NANDA book, okay? I recommend Sparks and Taylor. No, the school doesn't offer to you, but Sparks and Taylor wrote a very good nursing diagnosis workbook. It comes in pocket size. You take that to clinical with you, and it comes in regular size. $15 on Amazon, and you'll have it for 2 years, and it'll be great for you. Okay. Now we can do our interventions. Yes. The authors are Sparks and Taylor, and then it's a nursing diagnosis handbook or something like that. So therefore, now we can do our interventions, and now we can plan, and now we can carry out. Up to here, I was just thinking about being a nurse. Well, this is nursing, but now I'm going to be the nurse, hands-on. I'm going to provide IV fluids. We're going to give them an IV fluid bolus. We're going to give them the whole bag per doctor's orders, and then we're going to run it at 75 cc's an hour, 100, 125, 150 cc's an hour, depending on the size of the patient. Okay, and to make sure that they don't have any sort of heart failure, anything that's going to overload the patient with fluid. And then we're going to provide Zofran or Reglan every 4 to 6 hours as ordered by the doctor. Okay, and we're going to ambulate the patient. We're doing the work. Okay, and that's what we do as the intervention. The evaluation, we're going to evaluate. It's basically what I did it work or not? So it's going to be in, if you want to write this part down, it's going to be in 3 aspects. Goal met, goal not met, or goal partially met. Goal met, period. Goal not met. Goal partially met. Okay. I'm going to show you how to write a goal when we get to nursing diagnosis. Okay? All right. So there you go with your, basically what I call the nursing process. Okay? Very simple. That's what we do. Okay? All right. We're going to go to the nursing care plan, and I'm going to incorporate this nursing diagnosis. You ready? This is going to save your instructor 2 hours next week. Please save me 2 hours next week by understanding what I'm about to tell you. And this is what we use here. Let me make this a little bigger for you. Bring a blank copy of this next week, please. At the top is basically your student name, your instructor, the patient initials. Guys, please do not use real names on these patients. We can get in big trouble. That's a HIPAA violation. Okay? And remember, this is a pass, no pass class. Okay? Even though you want to score your grade to kind of allow you to know where you're at, the skills that we provide you the information of. Okay? But please, that's one of the things that can really get us in big trouble. Okay? One time, about a year and a half ago, a student brought a whole chart of the patient. They copied it all. The official rule is you're not allowed to copy anything from the hospital, the nursing home, and bring it with you. It has patients' names, it has doctors' names, and you're not supposed to do that. So don't do that. Okay? Get all your information there quickly. But somebody brought a chart, and they were sitting on the front row just like this, and the professor said, "Hey, what's that?" "Oh, this is the chart from the hospital." Whole name on it. So it was a sticky situation, and we had to take care of it. The schools took care of it. Almost lost the site. So don't do anything like that. And every school's been guilty of that as well. So be careful. Patient's initials only. Code status. It's going to be two answers. DNR or full code. DNR or full code. It cannot be both. Full code means we will do everything possible, including chest compressions, CPR, and mechanical ventilation to keep the patient alive. Heroic measures. Okay, so you need to understand whether your patient is DNR or if they are full code. DNR means do not resuscitate. Do not resuscitate. If you find the patient and they are not breathing, they're cool to the touch, you check the vital signs, there's no heart rate, there's no blood pressure, there's no oxygenation on the SAT probe, you know that something is wrong, right? You've got to do what next? Check what? Check the code status. So either should be on their wrist. If it's DNR, they're going to have a wristband. Should have a wristband. Or have the chart right there with you and check it. Really quick, call for help, do whatever you need to do. If it says DNR, you do not start CPR. You call your team, do a further assessment, you need someone else to check it out. You're going to call the house supervisor. I'm speaking in the terms of hospital life. Call the house supervisor, call the charge nurse. Keep trying to check the vital signs. Keep trying to check. And after about 2 minutes of this, you should know whether the patient is alive or not. Okay? If the patient is full code, you're going to start CPR and you're going to scream for help. Okay? So that you can get help, and the code team comes in, code blue to room 501. And here they come. And let those specialists do what they do. You start the CPR, but the code team will come in, which essentially is basically the ER doctor, EMTs that work in the ER, or any other RN, anybody, all hands on deck, CPR, start more lines, start more IV fluids, get out that epinephrine, get out the crash cart, okay, epinephrine, whatever it takes, and start getting the patient all coded up. Okay, code the patient and do what you need to do. They are a full code patient, so that's what goes here. DNR. Let me explain a little bit of something. Patient is a hospice patient. Any medics here or EMTs that have driven in ambulances? Okay. So you pick up a patient and the patient's on hospice. And they're DNR, you see it there, but the patient says, I want him to go to the hospital. What do? if you're out there on the street with an ambulance. You bring them to the hospital. The family can revoke hospice whenever they want. Don't ever let some hospice person scare you. Oh, the patient can't go to the hospital. They're on hospice. Well, the family wants them to go, so they're going to go. They've just revoked hospice. Drop the mic. Okay? Because the thing is, they bill on a daily basis. I worked for hospice for 6 years. They bill on a daily basis. The moment they don't bill, the patient goes to the hospital, they can't bill. So that's why that's their money. Okay? And they want to be able to handle everything at home. Patient gets to your hospital. Patient fell out of bed. They're on hospice, and it's evident that they broke their leg, broke their hip. But they're DNR, and they're suffering. And their blood pressure is going down because now they're bleeding internally. And their leg is not getting any circulation. But you know that you have the hospice contract right there, and it says DNR. Do not go to the hospital, call the hospice agency. You're the RN. Doctor's busy. What do? You take care of the patient and start and take care of the patient. IV, blood work, oxygenation, vital signs, EKG. And then the doctor, what's going on? Patient's on hospice and they're DNR, but it looks like they fell out of bed and broke their leg. Okay, let's get an x-ray. Let's get some pain control and let's take care of it. Okay, and hospice agencies have called my ear. This patient's on hospice. We just want you to know. We know that our nurse was there. The ambulance took them. They're on hospice. Well, not anymore because they're in the hospital. That's how that works. Okay, so code status is DNR, or code allergies. Put everything down. That includes medicine, products, plastic, latex, fruit, kiwi, frijoles, anything that they're allergic to. You're going to put it right there, and people can have many. Okay. All right. To the top right, the date of that date. Your course is going to be your course, unit, and room. Be careful with that. I mean, don't get too descriptive. Okay, but you can put Highland Park, 1980. Stuff like that. Date, patient's date of birth, not yours. Patient's date of birth, height and weight. And let me give you a little secret and put a little cloud on your notes. Find the face sheet of the patient. Find the face sheet of the patient. Because when you find the face sheet of the patient, it's going to have a lot of this stuff on it. Okay? It won't be, you won't have to search too far. That'll have their code status. It'll have their past medical history, which I will get to. It'll have their height and weight. It'll have their diet. It'll have the name of the doctor, the name of their family. So find the face sheet. Okay? All right, so let's get into our top line right here. Can you guys see that okay? Do I need to go a little bigger? There we go. Temperature. Each time you go to the patient, so what I hope happens is you're going to be introduced to this information on day one. In your first 4 hours of being there, you're going to be helping the CNAs, you're going to be helping the nurses, you're going to get the patient cleaned up, get them ready for the day, checking some vital signs. And I want you, and you'll do that for several people, and go from room to room with your staff member and just go help everybody out. I want you to be at that moment looking for the patient that you just kind of feel like, I want to do my report on this person. And find that person, and remember, two students cannot work on the same patient as far as the care plan. You will work together as a team, but okay, I call it, like, this guy's mine, okay? So do that, vital signs. All right, here's where it gets fun, because up till now it's been kind of just not fun. And I know you guys had lunch, and everybody's actually looking pretty good right now. So, all right. History of present illness. And then look at history of present illness right here. But down here, you see relevant, what is it? Past medical history. Did they change this sentence? Okay. History of present illness and past medical and surgical history. What's the difference? So let me go to B. Past medical history can include diabetes, hypertension, small bowel obstruction, right? Partial amputation of the right foot, hypothyroidism. Okay? We're talking about nursing 101, nursing home type patients. Of the things I just mentioned, those will not be reasons why the patient is living there. Let me say that again. Hypertension, diabetes, small bowel obstruction in the past, partial amputation. Those reasons are not enough for the patient to go live there. Okay? I'm 48. I know, you're amazed. If I go to Highland Park or if I go to Waterman Convalescent right now, and I say, hey, I'm David and I wanna live here. They're gonna be like, excuse me? Yes, I wanna live here. Can I go live there? Well, they're gonna first say, well, do you have Medi-Cal? Do you have Medicare? No? Do you have disability insurance that covers your room and board in case you were having a chronic illness which you're not going to recover from? In other words, like a hospice type diagnosis. No, I'm pretty healthy. Okay. So why do you want to come live here? I want to just live here. I like bed. I want to interact. Can I go live there? No, because these licensed facilities are licensed to only admit patients that qualify or have a qualifying admitting diagnosis. So that's what's going to go here. The history of present illness, including admission diagnosis. That is super important. What's the admitting diagnosis? And if you're with me, and if I have you for every single class for the time that you're here, I'm going to ask you in the hallway, what's the admitting diagnosis? Why are they here? So usually in these places where we're going to go to are going to be diagnoses like what? Dementia, Alzheimer's, failure to thrive, CVA, which is what? A stroke. What is their reason for being in the nursing home? That's the answer. And it should be 1 or 2, maybe 3. Well, they got high blood pressure. That's past history. Well, they got diabetes. That's past history. The patient might not have any diabetes or high blood pressure, but they've got dementia and Alzheimer's. Okay, have you seen them? They look very neat. They're always wearing their slacks, their shirt with their walker, and they're just kind of walking like this. That Alzheimer's, there's a name for that. Okay, a shuffling gait. Very square, okay, mask-like appearance to the face. That's why they're there, because Grandpa Joe can no longer live at home because he's wandering around, he's losing weight, a certain amount of weight when he's assessed. He's having this thrive situation where he cannot eat, and he's just losing weight, losing muscle, and he's wandering. And his mental status is not controlled anymore. That's the diagnosis for Grandpa Joe. Okay? So just remember that. Now, I'm going to go with how I would like my class to do it, and Professor Jenny can do it however she wants, and your other instructor can choose however they want to do it. I'm just going to give you the basic tools and how I would want it done. When you write down this first diagnosis, let's say it's dementia, I want you to write dementia, okay? And then I want you to write, let me go back to my word page. Let's just say, so it's basically going to go like this. And then there's your definition, period. Okay, I know I wrote all that. Dementia, dash, space, the definition. The definition has to come from your pathophysiology book. Okay, so find it. Don't Google it. Don't Wikipedia it. Okay? And then a period. 2 to 3 to 4 lines. No quotations. This is in your own words. Okay? Define it for me. The same book, you're also going to define the second diagnosis. And what if it says CVA, which is cerebral vascular accident? Same thing. Okay? It's going to start off with some sort of hemorrhage, of this and that. So please go ahead and give me the full definition of that. Okay? Any questions up to this part? It's going to be 1 or 2 or 3 diagnoses. These are the admitting diagnoses. I can't get into the nursing home because you know, well, sir, do you know that if you don't have any insurance, and this is true, it's about $6,000 to live in a nursing home cash. If you don't have the money, I mean, if you don't have the insurance, or the Medi-Cal, or the Medicare with benefits into a nursing home. Well, what if I say, I have the money? I don't have the money, by the way. But I want to live here. You know, I have the money. I want to live here. I can't, because why? I don't have the facilities licensed to take patients who have those diagnoses. So please keep that in mind. The past medical history is going to be, and your instructor should show you the list and help you out with this part. We're going to be standing at the counter in the afternoon next Monday after lunch, and we're going to be going through this for a good 2-3 hours, getting all your information while at the same time helping out taking care of patients. Okay? All right. So we have our living diagnosis of past medical history. Let's go here. Relevant diagnostic procedures. Okay, this is what you need. All your labs, but they live in a nursing home, they might not have labs. Let's say 6 months to 12, let's go back 6 months to a year. Anything, so these people still get labs done. Or what if, you know, Jenny Sue over here, 88-year-old female, had a urinary tract infection. The lab came over, drew her blood, took her urine, and sent it off. You will find the old, these are all old school charts. They open up, they have plastic tabs, and you're going to find the tab that says lab. That's where you're going to find that. Just look.
You're at 10%. That's okay. Just go.
That's good.